Welcome everyone to our second citywide psychiatry grand rounds. It's a delight to see everyone here today. I want to thank all of you for coming today and attending our virtual citywide grand rounds. Without I'm going to pull up my slide deck. Just give me 1 second. Okay. I want to first do a land acknowledgement. Please take a moment to situate yourself and think about the land under and around you. Since these rounds are virtual gathering, a single land acknowledgement does not capture the richness of our distribution across many locations. There are a few places on Earth that someone before us has not called home. We recognize that many indigenous nations have a long-standing relationship with the territories upon which the sites of the Department of Psychiatry are located that precede the establishment of the University of Toronto. We acknowledge our presence in the traditional territories of many indigenous nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, and Haudenosaunee, and the Wendat people. Today, this land is home to many diverse First Nations, Inuit, and Métis people, and we are grateful to have the opportunity to live and work and gather on these territories. We acknowledge that Toronto is covered by Treaty 13 signed with the Mississaugas of the Credit and the Williams Treaty signed by multiple Mississaugas and Chippewa bands. Thank you for that. Today's grand rounds, at the end of the grand rounds, we're going to have evaluation link sent to everyone. So please take some time to complete the evaluation. Your feedback is always important as we work on improving things and adding things to these grand rounds. So please kindly do that. I would like to give a special thank you to Dr. Tom Unger and the St. Mike's Unity Health team for their coordination of these rounds. And I'm very excited today. A special thank you to Dr. Corinne Fischer, who is talking today on photomodulation. And thank you for doing this talk for us on behalf of the department. And today we have Dr. Venkat Bhat, who is going to be the moderator for the session today. And thank him as well for being able to be present today for our grand rounds. I'll now move to our Vice Chair of Clinical, Vicky Silopoulos, for welcome. Vicky, go ahead.
Thanks, Raz. Welcome, everyone, to the second citywide grand rounds of the Department of Psychiatry. Thank you to Unity Health St. Michael's site for organizing the exciting talk today. We received so much positive feedback after the first grand rounds from Sunnybrook that we decided that it is time to go to monthly joint grand rounds as of next academic year. So exciting news to come. So stay tuned. We'll be able to provide more information in the months to come. With that, thanks again for joining and enjoy the presentation.
And now I'll move on to introduce Dr. Tom Unger, who's the Chief of Psychiatry at St. Mike's Unity Health. Tom will say a brief welcome and introduce our speakers.
Thank you, Raj and Vicky, very much for the kind introduction, and a real privilege to be hosting the citywide grand rounds from St. Michael's Hospital, part of Unity Health Toronto. So I'm just going to introduce briefly our two speakers that we're thrilled, and thank you to Dr. Ballero, who helped organize this rounds locally as well. Dr. Corinne Fischer is a staff psychiatrist with the Mental Health Service and co-director of the Neurodegenerative Research Division of Neuroscience Research at the Keenan Center for Research at St. Michael's and associate professor at the University of Toronto in the Division of Geriatric Psychiatry. Her main clinical and research focus centers around neuropsychiatric symptoms in Alzheimer's disease and their clinical, imaging, and pathologic correlates. Our discussant today is Dr. Venkat Bhat, and he's staff psychiatrist at St. Michael's Hospital and at UHN. He holds research appointments at the respective hospital research institutes and is assistant professor in the Department of Psychiatry at the University of Toronto. At St. Michael's Hospital, he's the director of our interventional psychiatry program, which is burgeoning and growing with a clinical focus on offering novel and emerging treatments for mood and comorbid disorders, and a research focus on understanding treatment response with the novel interventions we look forward to your presentations. Thank you.
Well, I wanted to thank Tom, Raj, and Vicky, as well as Shri, for organizing these rounds, and Venkat for moderating. It's a real, true pleasure to be here and present on some of the work that we're doing. So without further ado, just to start off by way of disclosures, I do get some funding from Hoffman LaRoche, Cortexime, and Vlight Incorporated. I also have some funding from Brain Canada as well. I'm not going to be discussing off-label medication, but I will be discussing a technology developed by Vlight Incorporated that's really the focus of the work we're doing, called the Vlight NeuroRx Gamma. So here are the objectives. I'm going to provide a conceptual overview of photobiomodulation therapies as compared to other neuromodulatory therapies. Talk a little bit about the basic science, anecdotal evidence, and clinical trial evidence for photobiomodulation in Alzheimer's disease. And then I'll provide an overview of potential applicability to other disorders of a neuropsychiatric nature. So just to begin, photobiomodulation is defined as the utilization of non-ionizing electromagnetic energy to trigger photochemical reactions within cell structures that are receptive to photons. So that's the basic definition. One thing that we know about photobiomodulation is that it targets the mitochondria very well. And if you remember your high school biology days, mitochondria are the organelles within cells that are responsible for the production of ATP. It was first discovered in 1967 by Andre Mester at the Semmelweis Medical University in Hungary. And at the time, he was trying to cure cancer, and he used a laser beam that was somehow inadvertently low powered. And so he made an error, and out of this error emerged this new technology of photobiomodulation. So what he did notice when he used this low powered laser, he noticed some unusual things. He noticed that the mice, rats he was working with, had an increased rate of hair growth, and the wound healing actually became accelerated. So those were interesting observations that led to other applications of photobiomodulation that I will discuss. And here's a photograph of him back in the 1960s. So one thing we know quite well, based on work done by many scientists, Michael Hamblin out of Harvard is a leading authority in the area of photobiomodulation. One thing we know, as I mentioned, is that it really enhances the functioning of the mitochondria. It also can reduce inflammation of the brain. It can modulate brainwave patterns. And it can also, interestingly enough, target AD pathology. We know that many of these mechanisms underlie neurodegenerative disorders, but also a variety of neuropsychiatric disorders. So there's at least a theoretical reason why photobiomodulation might be a good fit for a number of the disorders that we see in clinical practice. And so there's at least theoretical evidence for its use in a variety of brain disorders that run the spectrum from traumatic brain injury to major depression, to schizophrenia, anxiety as well. What we don't have, though, yet are definitive clinical trial data. So if we think about photobiomodulation, there's a number of terms that have been used over the years to refer to photobiomodulation. Photobiomodulation is probably the most recent term, but phototherapy is another one. Low-level light therapy or laser therapy is another one. Low-power laser irradiation is another term. Photoneuromodulation, then transcranial near-infrared laser therapy, near-infrared light therapy, and transcranial laser LED therapy. Those are some other terms. So one of the thing that's the important developments that's evolved, I would say, in the last decade, in particular in the last 5 years or so, is this notion that you can actually apply photobiomodulation to the head, and that the photobiomodulation, that the infrared light can be absorbed through the skull, and essentially treat underlying brain diseases. So most of these photobiomodulation devices were first approved by the FDA in 2010, and the principal reason was to reduce pain and inflammation. So they were used to treat tissue pain and inflammation. The more cognitive aspects of these devices have only emerged recently. They're relatively safe, minimal side effects. And as I said, in the last 5 years or so, there's been new applications that have emerged with respect to the brain, knowing that the infrared light can be absorbed through the skull. So they are approved. Many of these devices are approved by the FDA as general wellness devices. So this is extracted from an article by Michael Hamblin, looking at the types of brain disorders that, in principle, can be treated by transcranial photobiomodulation. So you have the traumatic injuries. There's been some work, in particular in traumatic brain injury. The neurodegenerative disorders, I'm going to present a study we're doing focused on Alzheimer's disease, but there's been some work in Parkinson's as well, and some of these more atypical dementia syndromes. There's been some work looking at schizophrenia and depression, and then also some work in neurodevelopmental disorders, including autism and ADHD. So what does photobiomodulation do to the brain? Well, it does a number of things that are good. It increases the blood flow. It improves availability of oxygen. It enhances the production of ATP, improves the mitochondrial activity. It can also modulate brain oscillatory function and reduce inflammation of the brain. So this is just what I discussed earlier. The near-infrared light penetrates the skull, goes into the neuron, and then stimulates this organelle called the mitochondria. You get production of calcium and opening of calcium channels, and ultimately you get reduction in oxidative stress, and you get the production of ATP, which then improves inflammation and causes a lot of other good things. So the place of the mitochondria in neuropsychiatric disorders has been well described, and I think we're starting to understand more and more that the mitochondria plays a very important role in neuropsychiatric disorders. And in fact, there's a whole vast array of disorders in which mitochondrial dysfunction has been implicated. And this is a range of disorders from schizophrenia to pervasive developmental disorder. And while we have very good treatments in psychiatry for a lot of the disorders we treat in terms of eradicating symptoms and addressing some of the other therapeutic issues, we don't have good treatments for this mitochondrial dysfunction that we see in many of our disorders. And so one question is, could we be using photobiomodulation as an adjuvant to some of our treatments to help with that aspect of these disorders? And similarly with inflammation, you've seen certainly in the last decade, a burgeoning interest in the role of neuroinflammation as it pertains to psychiatric illness. In particular, with the evolution of or understanding of autoimmune disorders and the extent to which they can really mimic some of our neuropsychiatric conditions. There is a role that's being played by inflammation, and similarly, though we have very good treatments for psychiatric illnesses, we don't have very good treatments for brain inflammation. And there is this strong link, as we know, between autoimmune disorders, in particular neuropsychiatric conditions. And I think that's been borne out by studies that have been done amongst patients that have, for example, autoimmune encephalitis, where it is primarily an inflammatory process of the brain, and addressing the inflammation is crucial to someone getting better. But we know from biomarker studies in patients that have depression and schizophrenia, bipolar OCD as well, that inflammation plays a really important role. And again, while we have effective treatments, we don't have treatments that really address the inflammatory aspect. So this is a good paper. Was done by Yang and colleagues that really looked at the current application and future directions of photobiomodulation in diseases of the central nervous system. And they looked at, the existing literature to try and identify potential applications, if you will, of photobiomodulation. So, and they, they found papers relevant to stroke, traumatic brain injury, Parkinson's, Alzheimer's, depression, and other diseases as well. So this is a quote from their paper. Photobiomodulation has wide applicability in the treatment of stroke, traumatic brain injury, Parkinson's disease, Alzheimer's disease, major depressive disorder, and other diseases. Our analysis provides preliminary evidence that photobiomodulation is an effective therapeutic tool for the treatment of central nervous system diseases. That's a quote from their paper. So, so one way to kind of gauge the sort of the interest in this area is to look at published scientific papers. And if you look at the trajectory of interest in photobiomodulation, it's really accelerated in the last 5 years or so. In 1992, there was one paper on photobiomodulation. In 2015, there were 60. And then in 2020, there were over 500. So, and who knows how many there'll be next year and years to come. But it's projected that the interest will just go up. And there's, in fact, currently over 3,000 published papers on photobiomodulation. This is just, there's also a number of these devices have been developed over the last, over the last decade, initially to treat tissue inflammation, and then more recently to treat brain function. So we have a number of the devices that manufactured by Vlight, the NeuroGamma, which I'll talk more about, the 810, the Alpha. And again, they have different frequencies and different targets. There's other devices as well made by other companies, the China Brain Wellness device, the Thor Light Helmet, and the Optimal 300. So I'm just going to talk about a few studies that have looked at photobiomodulation in some clinical populations outside of neurodegeneration. And then I'm going to focus more closely on neurodegeneration. So just to start us off so in terms of stroke studies, so this was a study done on 660 patients that had acute stroke. 331 were randomized to transcranial light therapy, 327 to sham. There's no change in outcome, but no safety concerns were raised. The device and the photobiomodulation was well tolerated. Cognitive impairment was not a focus, and they used the Neurothera laser system at a wavelength of 808 nanometers. They applied the device at 20 sites for 2 minutes, both active and sham, and they didn't find anything. They didn't find anything in terms of outcomes in that particular study. This is a study by Margaret Naser, published in 2014. Margaret Naser has done a lot of work in the area of photobiomodulation, specifically as it pertains to traumatic brain injury. And this is one of her studies that has looked at, again, cognitive functioning in patients that had mild traumatic brain injury. It was an open label study, but they found significant results. So these were 11 patients. They had a history of mild TBI. They were treated for about 6 weeks, 3 times per week, so 18 sessions with a transcranial near-infrared light device made by Medex. The LED diodes were placed on the skull, targeted the nodes of the default mode network and salience network. And then they did testing 1 week, 1 month, and 2 months post a treatment, and they noticed significant improvement in a number of neuropsychological domains, including tests of memory and executive function. So they got a very positive result, and she's gone on to do more studies that are currently in progress. This is a study done by Michael Hamblin and colleagues looking at depression in patients and seeing if we can use photobiomodulation as a therapy to target depression. So in this study, they recruited 10 patients that had a diagnosis of major depression. They use the near-infrared light treatments administered to the right and the left forehead for 4 minutes duration in a random sequence, and they alternated active treatment with placebo at 810 nanometers. And then they repeated the PANIS, the depression scale, after each treatment, and the HAM-A and HAM-D scales at 2 and 4 weeks post-treatment. And what they discovered was an improvement in regional cerebral blood flow, and 6 out of 10 patients underwent remission of symptoms with marked improvement. So another target for patients for photobiomodulation essentially are patients that are generally well, but want to enhance their cognitive performance or athletic performance. And a lot of these devices have been used by athletes, for example, to give themselves a bit of an edge, or by people who do tasks that are very cognitively taxing to give themselves an edge. So there's people that use them talk about an improvement in focus, less inflammation, they feel better, generally improved sleep and concentration, sort of improved general wellness, they feel more energetic, and they feel generally better. So I want to shift somewhat now to discussing neurodegeneration, because that's my primary interest. When we look at the landscape of Alzheimer's disease and treatments for neurodegeneration, we do have treatments that are fairly well tolerated, but probably modestly effective. In other words, they help a little bit, but they don't alter the disease trajectory in a meaningful way. Although they do help with some symptoms, and they can improve some domains of cognitive performance. There are some promising anti-amyloid therapies on the horizon. Aducanumab is one of them. There are a number of other ones. So we're just starting to see, hopefully, we're going to start seeing some of these anti-amyloid therapies that have shown some promise join the market. But the reality is there hasn't been an approved treatment for Alzheimer's disease since 2003. And the growing consensus among experts is that if we're going to develop an effective treatment, we need to have something that's multifaceted. It has to target many neurotransmitters and many processes. So we want something that targets amyloid and tau, inflammation, improves blood flow, that targets some of the things that PBM has the capacity to target. So if we look at the progression of Alzheimer's disease, for those of you who don't work in the Alzheimer's field, you see what healthy brain tissue looks like. You see what severe Alzheimer's disease looks like. And this is how the disease progresses. It starts off in a pre-symptomatic phase with amyloid deposition. And then you get synaptic dysfunction and decreased dendritic arborization in the pre-dementia phase. And then you get decreased neuronal cell bodies and axons in the mild and then moderate and severe stages. So you get this deposition of beta amyloid. Then you get this cascade of neurodegeneration involving tau and cognitive changes that are first perceptible some years afterwards. And then you get atrophy and dementia, and things degenerate from there. So, and then again, neuronal integrity declines over time. You have the accumulation of amyloid plaques and neurofibrillary tangles. You have changes in tau. You have atrophy of the brain. You have hypometabolism, altered brain activation. You have microgliosis, inflammation, amyloidosis. And then there's genes that also can predispose to dysfunction. This is an excellent review of the topic by Lim. Lewis, the CEO of Vlight Incorporated, also has done seminal and pioneering work in photobiomodulation for many, many years, and has patented many of the technologies that have targeted the brain in the area of photobiomodulation. So in his paper, he talks about the function of the mitochondria, that photobiomodulation, again, increases ATP production. But it also, there's evidence, for increased blood flow, reduced inflammation, and it also targets markers of neurodegeneration. The other benefit is you can deliver it at a physiological frequency of 40 hertz, and you can target brain networks such as the default mode network and the salience network that are so important to neurodegeneration. So this is just to, again, to emphasize one common question that gets asked is, can the light penetrate the skull? And it's very clear from studies that it can. Again, you know, the greater the wavelength, the greater the thickness of skull that can be penetrated. So what do we know from our animal models? We know that that you can actually reduce levels of tau and amyloid through the application of near-infrared light to rodent models. So again, this was a study that looked at K3 transgenic mice. They were bred to have, as an FTD model, to have a high concentration of hyperphosphorylated tau. And in this study, there were 3 groups that were compared: untreated wild-type mice, untreated K3 mice, and the near-infrared treated mice. And the near-infrared light was applied 20 times over a 4-week period. And what you see is quite striking in the treated. This is the control sample. This is the K3 sample of mice where you've got a high concentration of tau, or tangles here. And then if you compare these mice to the treated mice, again, you see that there's a marked difference in terms of the prevalence and concentration of the tau in the brain after treatment, which is quite striking. And similarly with amyloid plaques, again, pre and post, or not pre and post, but rather these were different samples. If you look at the treated mice compared to the untreated mice, there's a substantial difference in terms of the concentration of the amyloid plaques, both in the neocortex and hippocampus. So another study used transcranial laser therapy administered to transgenic mice using a near-infrared light device. It was administered about 3 times a week, and the mice were about 6 months of age when the light was administered. The reason being that's when these markers tend to peak. So what they were able to show was a decrease in amyloid load, inflammatory markers, and improvement in behavior relative to a control cohort. And the reduction in these inflammatory markers was in a dose-dependent manner. You saw, again, reduction in inflammation, mitochondrial functioning improved, and importantly, the behavioral indices also improved. So, I mean, just to summarize, there's a lot of potential mechanisms here. Increased neural activity, decreased apoptosis, decreased plaque formation, increased mitochondrial functioning, reduced antioxidant effects, and then anti-inflammatory effects. So this is an important article by George Perry and colleagues. It talks about the importance of mitochondrial dysfunction as a trigger of Alzheimer's disease pathology. We're learning more and more about the importance of the mitochondria as a, excuse me, as an important contributor to neurodegeneration. So there seems to be a consensus. The treatments need to be multifaceted. We can't just target one neurotransmitter. We need to target multiple. And there also is a consensus that in addition to therapies that we develop that target amyloid and tau, we need to look at some of these other pathways to neurodegeneration, inflammation, and mitochondrial dysfunction. Most of the treatments we have so far really are targeting one aspect: anti-amyloid therapies, target amyloid, cholinergic therapies, target acetylcholine. So again, just a reminder, Alzheimer's disease is a complex disease. There are contributors, things that we think predispose: traumatic brain injury, menopause, brain infections, neurotoxins. And these lead to the triggering of the disease. You have accumulation of amyloid and tau. You have inflammation as a later stage process. You have genetic contributors. You have inflammatory contributors. So it's a complex disease. And again, there is a role to be played by mitochondria, and it's often in the preclinical phase that we see this. And then, you know, there's a threshold that's reached after the preclinical phase, and you develop these inflammatory markers which tend to accumulate over time along with the neurodegenerative markers. And again, as time progresses, you get more mitochondrial dysfunction. The other thing that's important to bear in mind is that for memory to be consolidated, it needs to be, there needs to be a certain brain, there are certain brain frequencies that are optimal. High frequencies are preferred over low. In particular, frequencies that match physiologic frequencies. So administering a light at 40 hertz is more therapeutic than administering a light at 10 hertz. And this demonstrates this, that, you know, looking at 40 hertz, you get improved memory consolidation in the hippocampus. Again, high frequency oscillations are good for encoding of information, and the low frequency oscillations tend to be bad, as does epileptiform activity. This is another study that again looked at the role of gamma frequency in terms of attenuating amyloid load and modifying the microglia. This is a study by Rees and colleagues from CAMH looking at near-infrared light, looked at healthy controls. It was pulsed at 40 hertz and it targeted the default mode network. Again, these are 20 patients, double-blind study. I guess 10 were randomized to active treatment and 10 to sham. And it was a single session of transcranial photobiomodulation. And those that were randomized to the single session of transcranial PBM had higher oscillatory frequencies of alpha, beta, and gamma, and reduced lower frequency signals such as delta and theta. And that was in contrast to the sham treatment. So this is just a picture of the device, the NeuroGamma RX that we are using in our study. So you see that there's a probe that goes in the nose that targets the hippocampus, and then you see these nodes targeting various nodes of the default mode network. So the default mode network, I think, is another important discovery that has implications for certainly Alzheimer's disease, but other neuropsychiatric conditions as well, as it's been shown to malfunction in these disorders. Default mode network encompasses a broad network of various regions of the brain that include the medial prefrontal cortex, the posterior cortex, precuneus, and the angular gyrus. And it's interesting because this is the network that turns off when we're doing, or actually turns on when we do absolutely nothing. So if we're sitting and daydreaming, that network turns on. So this is, you know, you could, in terms of some of the photobiomodulation devices, this is an anecdote from a patient whose relative used one of these devices. It's also astonishing. Alzheimer's has almost completely reversed itself, erased the past 10 years of neurodegeneration. The obsessive behavior has stopped, regained ability to speak. Short-term memories improved dramatically. Can now feed himself, engage in normal conversation, able to recognize those around him. It's also astonishing, far beyond what I expected. So that's an anecdote. Obviously, not every anecdote is that positive, but it gives you a bit of a window into what some of the devices, what the potential of this technology is, and what this may do in time. So if we look at clinical studies, a lot of this work has been done by one of the seminal papers was a paper by Anita Saltmarsh out of McMaster. And they looked at 5 patients with moderate to severe dementia, and they used transcranial photobiomodulation to target the nodes of the default mode network. The 12 weeks of active treatment followed by a 4-week washout. It was pulsed at 810 nanometers and pulsed at 10 hertz. They used the Vlight 810 and the Vlight Neuro, and they found a significant improvement in cognitive functioning relative to baseline and a precipitous decline post-treatment. Again, this is just 5 patients, so just to bear in mind, this wasn't a large sample, but nevertheless, the results were very impressive, and people did get, you know, this is the MMSE. This is after a few weeks, they got, you know, they got improved by 2 points, and then precipitously post-treatment, the scores went down similarly with the 8S-COG. Now you have to factor in the fact that this could be a placebo response. Also, this is only, again, 5 patients, so it's hard to interpret what this means, but nevertheless, there is some basis for optimism. Here's the how people responded. So these are the scores pre and then scores at 12 weeks. You see some fairly robust improvements, 24 to 28, and then back down to 25. 22 to 23, and then, or 24 rather, than back post treatment to 24, and then, from 10 to 12. So you see some fairly robust improvements. This study didn't look at neuropsychiatric symptoms objectively, but there were qualitative comments where people, talked about regaining some of their functionality, colors being brighter, the world seeming brighter, and some of the personality traits were restored. Most of the effects of the treatment were reversed after treatment was withdrawn. So this is just a reminder about our current treatments. Obviously, these are in large data sets that are placebo-controlled, so you can't make comparisons. But in terms of a target of where we're looking at what we want a treatment to be at least as good as, these are usually with cognitive enhancers. There's some improvement, and then there's a decline over time that may be a little bit less steep than without treatment. But on average, scores decline in Alzheimer's about 2 to 3 points per year. And then cognitive enhancers, there's an increase from about 0.2 to 0.4. And with our cognitive enhancers, our traditional medications, cognitive symptoms do decline, or cognitive scores rather do decline after time and after the medications are withdrawn. Even if patients remain on medication, there is a decline, although it's less robust than without treatment. And most people on cognitive enhancers will notice that they're a little more spontaneous and more engaged in activities. This case series does suggest some impressive results. This is just a reminder about the neuropsychiatric inventory, how these scores change over time with cognitive enhancers. This is another study, pilot double placebo-controlled trial, 11 participants, 6 active, 3 controls, 2 dropouts. Participants received 28 consecutive stimulations, and they used 1,100 LEDs set in 15 arrays, and they used QEEG to gauge improvement in the active treatment group. And in general, the blue represent active treatment, the green represent placebo, and in general, people that ran randomized to active treatment did better. This is an important study by Linda Chao out of UCSF. Looked at, I believe, 8 patients again with dementia or Alzheimer's disease, randomized to usual care or photobiomodulation. So here you have a placebo or a sham sample, and you see that in the PBM sample, the ADAS-Cog goes down. In the usual care, it goes up. And similarly, NPI scores in the active sample, the experimental sample, go down fairly substantially. Usual care, they go up. And so not only in this study, they also looked at some imaging biomarkers. They looked at arterial spin labeling and fMRI, and they noticed after 12 weeks of treatment that not only was there improved blood flow, but there was greater connectivity between the posterior cingulate cortex and the lateral parietal lobes. Those are nodes of the default mode network, so it's very important. How does PBM differ from RTMS? Venkat may speak more to this, but we know that it uses low-level light therapy as opposed to electrical stimulation. Devices are portable, can be used at home. They're approved by the FDA's general use. It tends to have more of an effect on whole brain function. You don't get a seizure, and it doesn't really alter the electrical activity of the brain. And in most cases, you use these devices daily, 6 out of 7 days a week, 20 minutes at a stretch. I want to just in the last few minutes here talk about our trial, very important trial sponsored by Vlight. We are using a device called the Vlight NeuroRx Gamma, and we're targeting patients that have moderate Alzheimer's disease. So there's a pilot phase, a double-blind RCT that's in progress, and I think it's about halfway there. Unfortunately, COVID affected our ability to recruit, so things have slowed down. And then there's the study that we're leading, the 228 subject pivotal double-blind RCT. It's going to be occurring, or that is already occurring actually, 8 sites across North America, including the US and Canada. So it's pivotal, it's randomized, double-blind, multi-centered. We're targeting patients that have moderate to severe Alzheimer's disease because that's where the inflammation is probably the greatest. It's one-to-one treatment with an active device versus sham. There are 8 centers across Canada and the US. Target population is 228 participants. And the study started recruitment in 2019. There are 3 active sites, Toronto, Ottawa, and I believe Florida, and Detroit, I believe, as well. Of course, this is all interrupted by COVID-19. So the study protocol for this study was developed by the ARC, and specifically as well in collaboration with Vlight and Peter Juni as well. So primary objective of the study to determine whether the experimental NeuroRx gamma device improves cognitive functioning and quality of life and reduces health care service as compared to a sham device in patients with moderate to severe Alzheimer's disease. The primary endpoint is the severe impairment battery. For those of you that don't know that, that battery, that's a battery that we use to evaluate cognition in patients who are moderately impaired. And then we're also looking at the Alzheimer's Disease Cooperative Study Activity of Daily Living Scale. So the SIB at 12-week, the ADCS, ADL, severe at week 12. We're also looking at some quality of life measures. We're looking at the NPI, that's a personal interest of mine, and we're looking at resource utilization and dementia. Obviously, we're going to look at safety, severe adverse events, device-related adverse events, rates of nosebleeds and nasal infection compared to 24 weeks prior to treatment initiation. And then we're going to look at anxiety and some of these other domains as well. So far, we've screened 33 subjects across 3 sites, St. Michael's Hospital, Detroit Research Center, and Briere Research Institute in Ottawa. And so far, 14 subjects have been randomized. We activated in June of 2019, but we shut down in March due to COVID-19. We had a few patients that were active at that time that we saw through, and I think we're going to be hopefully reactivated in the next month or so. So if you know of anybody who has moderate Alzheimer's disease who might have interest in this study, please reach out to me, get in touch with me. There's my email. We're actively recruiting patients. So just to sum up, photobiomodulation was discovered in 1967. It involves the use of low-level near-infrared light therapy to target neurons. It addresses theoretical mechanisms common to neuropsychiatric symptoms, which include inflammation, mitochondrial dysfunction, brain oscillation, and neurodegenerative pathology. We have some preliminary data on human subjects that suggests potential for improvement, but we need larger scale studies to verify this finding. I just want to thank all of the contributors to the study, in particular Vlight, Lou, Lim, Gina, Leshwaran, and then the group here, David Munoz, Tom Schweitzer, Luis Farnazari, Peter Juni, the ARC, Jessica Marches, the ARC as well, Felix Zip from Everest, and then Kamal Talib and Powell Castirco are the 2 coordinators that have been very important to the development of this study. Thank you very much.
Thank you, Corinne, for a nice, broad initial overview on this interesting topic, and then a focused an overview on its role in the context of neurodegeneration. I'll take 5 minutes to summarize some of the key strands from your presentation, and also present some of the key challenges. And then I've been taking note of all the questions, and I'll try to present them to you. I've myself not worked in this domain, but as the program lead for a new program, the interventional psychiatry program, where we're focusing on developing new treatments, this is of particular interest. So the concept of using light is not something new. So have more exposure to sunlight is an old adage. It's centuries old. And if you try to situate this in the context of where the current needs are, a lot of the work within brain stimulation has been for the acute phase treatments. There's been, in many ways, an obsession on the acute phase treatments, but we critically need take-home treatments. We really need the maintenance treatments. From that context, this fits the bill well: limited side effects, ease of use. And from a modality point of view, I think there are interesting possibilities. So targeting the mitochondria, inflammation, modulating brain oscillations. If you also look at this from the currently available treatment armamentarium, so you're looking at the treatments at the synaptic level, the pharmacological treatments, the electrical treatments like the neurostimulation treatments, modulating the electrical circuitry, psychotherapies. So in that sense, this is a different modality using light. So it does represent a different treatment modality. Now, in terms of the challenges, I think one of the key challenges is really moving this from the wellness realm to really the illness realm. And I think the work that you're doing is really important in moving this from the wellness realm to the illness realm. And it's true that it's working on the mitochondria, on inflammation, on modulating brain in oscillation. And I think the focus should also be on target engagement in terms of the neural circuitry and the specific regions which are involved, and correlating that with your outcomes. I mean, historically, we have done research where by serendipity, a lot of the discoveries happened, but it also took decades before treatments moved down the pipeline. And one of the ways to move it really faster is to have better biological correlates. And I think there's some interesting work coming out there. There's a paper by Paolo Cassano and looking at emotional modulation and transcranial illumination at the F3, F4 regions, as focusing on the dorsolateral prefrontal cortex, the best in target, the intranasal as closer to the cribriform plate, the ventromedial prefrontal cortex, and maybe wavelengths of 810 nanometer as being, providing the highest energy delivery. I think the challenge of really having an infinite, unlimited parameter space and narrowing it down to, even if the first treatments don't work, to be able to understand why and go back to do more definitive and, your pivotal, name actually, it fits in well there in terms of doing studies of this nature, which are actually critical. And if you look at light therapy for seasonal affective disorder, I mean, there was a biological link later on with circadian rhythms. One other thing I'll mention, and then I'll move over to the questions which have been coming in, is that light not only offers an opportunity to modulate the system, but actually also is a probe for the system. So if you look at the last decade and a half, one of the critical developments in the field has been optogenetics. So optogenetics uses light as a way to target specific neural circuits. It's at this time really for research within animal models, but you can see the possibility where specific neural circuitry could be targeted in some hypothetical way in the future. So although it's not a reality today, I think there are significant possibilities there. Okay, now moving on to the questions. One of the questions was, the treatment has been around for, photobiomodulation has been around for a while, and a lot of the studies have been smaller. They have been open label. And the question was, why do we have a limited number of RCTs? Corinne?
I mean, I think it's a good question. I think, I think although, this technology has been around for some time, it really hasn't been around for a long time. If you look at the, other similar kinds of therapies and how long it takes for these things to evolve, the refinement in particular with regard to photobiomodulation as it applies to the brain. I think there's been a lot more that's been done as it applies to brain tissues and inflammation, people with, for example, athletic injuries and so on, muscle aches, back pain. But if you look at the application to the brain, it really hasn't been all that long that these devices have been around and refined to the point where they can be used. So I think we're just starting to see the potential of this now.
Thanks, Corinne. Another question. What does this device feel like on the scalp? So the question is, placebo effects are important, and does the sham device accurately capture the placebo effect?
That's an excellent question, and my my understanding is that I believe it does. I mean, unfortunately, I don't have anyone from the actual. I don't believe anybody from the company is on the call, but my understanding is that it does. The one thing that some people will complain of when they have this device on their head, for example, is heat, is excess heat. So, but my understanding is that the sham has identical effects to the active device.
Thanks, Corinne. One other question which has been asked a few times is there a role for this being used at an earlier stage of the disorder as compared to at a later stage of the disorder? Do you think the effects might be different if it's used in early MCI as compared to the later stages?
I think they would be, simply because of the preponderance of inflammation, which tends to be more of a late stage effect. I mean, you could argue that in the earlier stages you have amyloid deposition, you have tau. Maybe it's helpful to use it at that level, but you could also argue that where is the inflammation most robust? It's really at the latter stages of the disease course. So I think that's certainly a direction that should be followed and should be taken, given that, again, we have a lot of patients that have early stage MCI, and we really don't have a good therapeutic. So I think that would be something to look at in the future. But I think the great evidence we have or good evidence, I should say, for photobiomodulation and inflammation, makes it probably a bit more suited to patients that have more advanced symptoms.
Mm-hmm. It's also a good segue for the next question, which is if there's a role in terms of inflammation, do you see a potential, combinatory or synergistic effect of using an anti-inflammatory agent with photobiomodulation?
I think that I'm not sure I don't really have a good answer to that particular question. I mean, at some theoretical level, it makes sense that something that you ingest an anti-inflammatory treatment, maybe that would help to potentially augment what's going on in the brain. I don't know, to be honest, though, in terms of the blood-brain barrier permeability, would taking something orally, would that penetrate the blood-brain barrier, and would that have any adjuvant effect? It's an excellent question. I just don't know the answer.
Mm-hmm. Moving on to other questions, we have a few. So there's a question regarding the photoreceptor feedback on the central body clock, such as at the suprachiasmatic nucleus and resetting of the circadian system, given that the circadian system has been implicated in dementia and mood disorders. Are there studies implicating or examining its impact on the circadian system level?
There may be, not to my knowledge in terms of the literature that I reviewed, but that's not to say that they haven't been done. It's certainly possible that's something that's been looked at. I just haven't come across it in my review of the literature.
Mm-hmm. Mm-hmm. I think from a mechanistic or a target engagement point of view, that might probably be one of the areas to critically examine in the future as well. There was also a question about, moving it from the wellness to the illness realm, which I alluded to earlier. And there are a few questions around it. And I'm wondering if you could, I think you've addressed some of them, but also what might be the kind of studies we need. There's obviously a lot of potential, but we have smaller studies and often not or limited target engagement or really biological correlates. So what are your thoughts on really moving this from the wellness realm to the illness realm?
Well, I think the study that's been designed that we're leading with Vlight and is really an example of the kind of study that's needed. So it's a double-blind, sham-controlled study involving 220 patients across multiple sites across North America, 8 sites. I mean, that is what is needed. We know what the FDA needs. The FDA needs a large multi-centered study to show efficacy. So I think that's what we're going to need if we want to move from illness to wellness. It's pretty well laid out by regulatory bodies in terms of the requirements. So I think moving in that direction would be a good way to go. And then once if there is an indication, once you get one indication, then it becomes easier to get others, of course. But it's going to take a lot of time, effort, and rigorous studies to answer some of these very important questions.
Thanks, Corinne. Another question was that you had mentioned that photobiomodulation is approved by FDA for pain. The question was, does this refer to headaches and or neuropathy?
Yeah, unfortunately, I would assume it would, but I don't know. Again, a lot of this is in the realm of general wellness. So, yeah. I don't believe there's a specific indication for these devices for a specific medical condition. But there is potential, for example, to help with levels of inflammation and pain. So.
Another question was about Health Canada approval. These are FDA approved, as you mentioned earlier. Would you be able to comment on their status with respect to Health Canada approval, and briefly, if you're aware of the cost of these devices?
So yeah, so the one obviously we're using for our study is Health Canada approved as well, so that we can use it for the study. The cost varies, I think, depending on the particular model and the company that manufactures it. So they could range anywhere from $500 to $2,500, and there's a vast range in between. Thank you,
Corinne. We are reaching the end of our time. I'll probably ask one more question. There are also one or two questions regarding comparative efficacy. So photobiomodulation as compared to other existing treatments, such as transcranial direct current stimulation, or maybe even RTMS. I guess usually you need to show efficacy before you do a comparison across treatment modalities. Would you be able to comment on that?
Yeah, I think that's another excellent direction to go in. There's numerous studies looking at TDCS and RTMS, and so to do comparative studies, just as you would comparative drug studies, I think makes a lot of sense. Comparing efficacy, is it more effective? Is it less effective? Is it effective in a different way? I think those are all very worthwhile things to do.
All right, I think we've reached the end of our time today. Thank you, Corinne, for an excellent overview of the topic, and also for, if I could say, shedding light on an understudied topic.
Thank you, Venkat. Thanks, everyone, for coming. I appreciate the opportunity.
Thanks,
Thank you, Corinne and Venkat. Corinne, a wonderful presentation. The feedback has been exceptional, even in the chat. Venkat really loved your analysis and feedback, and thank you for doing that. This is a wonderful talk. Just an FYI, we have our next Grand Rounds at CAMH, is hosting it on May 28th, and hopefully you'll be able to join us to save the date. Maybe I'll give one or two final words to Vicky and Tom before we end today.
Nothing else from me. I hope that you enjoyed the presentation, and we look forward to seeing you at the next Joint Grand Rounds.
Thank you, everyone. See you at the next Grand Rounds. Wonderful talk. Nice to see everyone. Take care. Bye.
Thank you. Bye-bye.